جزيل الشكر لدعوتي لإلقاء المحاضرة. أنا اسمي هادي يازجي، فخور بكوني طبيب خريج جامعة دمشق في دفعة 89. بتشكر اللجنة المنظمة وبشكل خاص أستاذنا العزيز دكتور إياد شطي على جهودهم
ممكن
الجبارة.
نرفع الصوت شوي إذا
بعتذر
تريدوا
منكم
الشباب.
لأني راح ألقي المحاضرة باللغة الإنجليزية، لأن اللغة العربية العلمية ركيكة جدا، ولذلك بنحكي باللغة الإنجليزية، وخصوصا أنه في زملاء من ما بيحكوا عربي، بس بفتكر بيفهموا باللغة الإنجليزية. We will talk briefly about estrogen receptor-based gene expression profiling in breast cancer and how this topic was evolved over the years. Then we'll discuss the application of immunohistochemistry as a surrogate tool for molecular testing, followed by a very brief discussion of the role of IHC in triple-negative breast cancer diagnosis. And then we'll talk about the treatment approach, which is also based on the testing, and also the molecular testing approach, which obviously is based on the treatment. First, I think everybody agrees that breast cancer is a mosaic disease. Not two cancers are similar, and this is illustrated here. All these are invasive breast cancers, and not two are the same. In 2001, an extremely important study showed up in the English literature, which shows that breast cancers can be divided, generally speaking, using gene expression profiling into two groups. One group that is positive for estrogen receptor gene expression, and the other one that's negative. And those two groups lead to a cascade of other gene expression based on the status of estrogen receptor. So as a result, we can actually use immunohistochemistry to mimic the molecular classification of breast cancer as luminal and non-luminal. So the top portion of the screen has the ER positive tumors. By definition, they are luminal. If they're HER2 negative and Ki67 proliferation rate is low, then they will be called luminal A. If the proliferation rate is high, then they will be called luminal B. If HER2 status is positive, they would be called luminal HER2. Now, if the breast cancer is negative for estrogen receptor expression, if HER2 is positive, it will be called HER2 phenotype or subtype. And if HER2 is negative, then by definition the tumor is triple negative. Then we look at the differentiation. If the tumor is not differentiated, is poorly differentiated, then this would be either a basal-like or triple negative, not otherwise specified. If it is differentiated, then it'll have to have one of the following diagnoses, either adenoid cystic or secretory or apocrine carcinoma. Among the triple negative carcinomas that is ER negative or triple negative, that is differentiated, apocrine carcinoma is the most common one. How is molecular testing used to guide therapy in breast cancer? In two major ways: risk assessment classification in the low stage tumors that are ER positive, and then the second role is ever growing, which is the detection of actionable mutations in high risk cancer patients. We're going to spend most of our time talking about the second group. Now, by immunohistochemistry, the standard of care of biomarker testing is still the same, ER/PR and HER2. ER/PR expression qualifies the patient of ER pathway targeting, mostly endocrine therapy, and HER2 expression or amplification qualifies the patient for HER2 targeted therapy. Generally speaking, 70% of breast cancers are ER positive, HER2 negative, 15% are HER2 positive, and 15% are triple negative. Let's just try to remember what the role of endocrine therapy in breast cancer, and that follows the synthesis and activation of estrogen receptor. First, the estrogen itself can be blocked by aromatase inhibitor, but we can also block the receptor either by tamoxifen or fulvestrant, and these act at the receptor level itself. So the resistance to endocrine therapy comes from the fact that either the estrogen receptor gene is mutated, the estrogen receptor gene is called ERS1, or PIK3CA gene is mutated, and that leads to resistance to endocrine therapy. I will talk about these later on. Now let's stay with the topic of ER testing in breast cancer. I was many years ago fortunate to be involved in a group that set testing guidelines of ER in invasive breast cancer. Our guidelines were taken by the American Society of Clinical Oncology, College of American Pathology, and used after I was invited by the group that designed the testing guidelines in 2010. Now, in 2020, a recent update was published, which actually included a very important subgroup, which is the group of patients where ER percentage positive cells is between 1 and 10%. We are not sure that these patients actually do respond to endocrine therapy. That's why we still call them low positive, but I suspect in the future, as more patients as more studies are available on these patients, we would probably call them negative, and then we will move the positive threshold to 10% as opposed to 1% where it is now. Other recommendations are mostly for quality control, quality assurance. We have to troubleshoot cases where the highly unusual ER negative results are reported, and these are usually the low-grade tumors, the pure favorable histologic types, and these papillary types. We also have to troubleshoot cases where there is a highly unusual ER positive results, and these are the high-grade tumors, metaplastic and adenoid cystic carcinomas, epicrine, and secretory carcinomas, which are expected to be negative. This is an example of an ER low tumor, and that's, again, is between 1 and 10%. My prediction that this group will become negative in the future as more studies become available. HER2, we can spend hours talking about HER2, but briefly, I remember when I was a fellow, in breast pathology fellow at the University of Washington, that's when it was reported for the first time a solid tumor targeted therapy, which is Herceptin, against breast cancer metastatic setting. Now we have multiple agents and, of course, multiple testing guidelines. I was fortunate enough to be invited to the 2018 guideline. Briefly, again, the correlation between the gene and the protein is very tight. If the gene is negative for HER2 amplification, the protein there would be very little protein produced, which is illustrated on the left side of the screen. On the right side is an example of a HER2 positive gene amplification leading to HER2 positive expression of the protein. Now, not all HER2 positive tumors are the same, as we have seen morphologically and clinically. So we have, before we talk about those, we have two groups, HER2 negative and HER2 low. The HER2 low tumor, I would like to define it on based on gene status, not protein status, and we can spend hours also talking about that. But the HER2 positive tumors is a heterogeneous group and can be placed in two main subgroups. The luminal HER2, which is by definition ERPR positive, has a nuclear score that is at most 2 out of 3, with a low HER2 copy number, less than 10, and a low Ki67 proliferation index, usually less than 20. Whereas the pure HER2 positive tumors, by definition, are ERPR negative and have a unique morphology that allows us to predict the HER2 status by just looking at the H&E. These usually have very high HER2 copy number and high Ki67 proliferation index, higher than 20%. In my opinion, these tumors are the ones where the patient benefits the most from anti-HER2 therapy because there's no other resistance. There's no estrogen receptor positive status that blocks anti-HER2 treatment. These are the ones that benefit the most. We cannot stop talking about HER2 without really mentioning briefly the role of mutation, HER2 mutation, which is irrespective of HER2 protein and gene status. It can happen. Usually, less than 5% of breast cancers are positive for HER2 mutation, only detected by either PCR or next generation sequencing. The mutations are usually clustered in the tyrosine kinase domain, which explains why these tumors, if we treat them with anti-tyrosine kinase inhibitor, they actually do respond. But if we treat them with Herceptin, they don't respond because the protein status is normal. This is something that is done in next generation sequencing panels, and if there is HER2 mutation detected and the patient is otherwise eligible for treatment, then they can be treated with neratinib. What is the role of immunohistochemistry in detecting and diagnosing triple-negative breast cancers that are very high grade and can be confused with other carcinomas? It is actually a growing role. We have here 3 different proteins, GATA3 protein expressed on the left and SOX10 expressed in the middle, and then TRPS1, which is the most recently described marker for triple-negative breast cancers and seems to be just as specific but also more sensitive than GATA3 and SOX10. This was described by the group at MD Anderson, and we use it, and our experience is actually identical to the experience of the MD Anderson group. The role of immunohistochemistry is excellent and superb in many applications in breast cancer, but it also has limitations. What are the limitations? Now, immunohistochemistry can predict endocrine therapy eligibility, can predict HER2 treatment eligibility, and it also can predict can define and determine eligibility in the MMR positive group, MMR deficient group of patients, and also the PD-L1 positive group in the triple negative category. What it cannot do is it cannot determine PIK3CA mutation. There's no mutation-specific antibody. It really cannot determine the tumor mutation burden. This has to be done by next-generation sequencing. And it cannot really determine the NTRK eligibility, even though there is an NTRK, pan-NTRK antibody. We use it all the time to screen the patients. But in terms of the specific mutation, specific translocation, it has to be determined either by FISH testing or by molecular testing. Also, immunohistochemistry cannot determine ESR1 mutation status. ESR1, as I said, is the estrogen receptor gene. Let's switch gear now and talk about the treatment a little bit. So here's the agenda. We'll spend a few words, we'll say a few words about NCCN guidelines, the most recent one. NCCN is National Cooperative Cancer Network. And we'll talk about the ASCO guidelines in biomarker systemic therapy in the metastatic breast cancer setting. We'll talk a little bit about the interaction between the biomarkers with biomarker testing by IHC, endocrine resistant therapy, which is a growing field, and we're knowing more and more about it as we learn as time progresses. We'll mention something about NTRK fusion, and then we'll stop a little bit, discuss the triple negative and aggressive tumors with regard to PD-L1 testing, MMR, MSI testing, and also tumor mutation burden testing. So I would like, this is a very busy slide, and the NCCN guidelines file or document is like a book, is 260 plus pages, very busy book. So if I can point your attention in the bracket in the red rectangle, which talks about the biomarker testing and it says biopsy of at least recurrence of disease, consider rebiopsy if progression, and then evaluation of ERPR and HER2 status, as in any breast cancer, and then comprehensive germline and somatic profiling to identify candidates for additional targeted therapy. And the details of that are in the following slide. So we have here all of the approved therapies and associated companion diagnostic testing related to patients with recurrent, unresectable local or regional or stage 4 disease. So again, these are patients with advanced disease. And this includes modalities such as BRCA1, BRCA2 testing, PIK3CA mutation, PD-L1 testing by immunohistochemistry, and NTRK fusion by either FISH, NGS, or PCR, and then MSI high or MMR deficiency by either immunohistochemistry or PCR, and then tumor mutation burden. The ASCO met, and they basically adopted the NCCN guidelines, which are identical. So in the next couple of minutes, we'll talk about the common theme and limited disease, limited tools. There's no need for additional tools. If the tumor stage and the luminal status are favorable, then this is a low-risk patient, doesn't require a lot of tools to treat, focus on endocrine therapy plus minus chemo or HER2 therapy. But if the tumor grade or the stage is high, then this is a higher risk, or if the tumor is recurrent or metastatic, then we need to explore actionable mutations and checkpoint-related biomarkers. So here is a cartoon of the cell cycle reminding us that of these cyclin-dependent kinases that really put the brake on or trigger the tumor to undergo progression from the G1 to the S phase by phosphorylating some of the proteins, the cell cycle protein, leading to progression. If we block some of these with therapeutic agents, we can actually slow down the progression of the disease. We cannot talk about Ki67 status without really talking about its role in differentiating luminal A from luminal B, and there is a very interesting work done by my colleague in Italy, Professor Giuseppe Viali, and his group, stratifying the patients into low luminal A versus luminal B by using a combination of Ki67 and PR score. If PR is higher than 20% and intermediate, and Ki67 rate is intermediate between 14 and 19%, versus lower than 20%, you can see the curves are different. These are prognosis curves related to cumulative incidence. Now, therapeutically, the MONARCH study, clinical trial, showed that actually there is benefit of giving anti-CDK4/6 treatment in patients who are ER positive with advanced disease, ER positive HER2 negative with advanced disease, showing survival benefit. Quick word about PIK3CA mutation. Turned out that 40% of ER positive breast cancers are positive for the mutation, which blocks the benefit of endocrine therapy, and 10% of HER2 positive tumors patients have that. Now, there is a FDA approved agent that is indicated in the treatment. With regard to the translocations, we're running out of time, but pretty much the adenoid cystic carcinomas and secretory carcinomas have specific translocations which have therapeutic applications, including NTRK. So NTRK actually has been approved for patients, again, with advanced disease, progressed after therapy. So there are agents, anti-NTRK agents that are used. PD-L1, we can talk a lot about it, so running out of time, but the idea is that the tumor produces antigens trigger the T cell activation, which come and attack the tumor, but the tumor outsmarts the T cells by binding PD1 with PD-L1, the ligand. So there is a therapeutic role here by either blocking the PD-L1 or PD-1 and reactivating the T lymphocytes. In triple-negative breast cancer, there are multiple couple trials that show benefit in giving anti-PD-1 or anti-PD-L1 in those patients. A quick word about, and this actually shows the difference in between patients with the combined positive score of 10 versus combined positive score of 1. There is a slight survival advantage when the score is higher, which is to be expected. MSI, MMR testing, basically any solid tumor qualifies the patient if the patient has advanced disease for PD-L1 and other therapies. In terms of tumor mutation burden, basically it's the total number of somatic coding mutations in a tumor. A tumor with a higher number produces more antigens, better target to immune checkpoint inhibitors. And the gold standard is the whole genome sequencing, not targeted NGS, whole genome sequencing. And it's substituted to targeted sequencing. And here is an example of a tumor, hypomutated tumor on top versus a hypermutated tumor, which qualifies the patient to endocrine therapy, immune checkpoint inhibitors. So in summary, the traditional biomarker testing remains the most important component of breast cancer workup. Molecular classification of breast cancer reinforced the importance of estrogen receptor status as a driver event. Addition of proliferation by Ki67 helps classify luminal tumors, but it also helps predict eligibility to CDK4/6 inhibitor therapy in advanced disease. And of course, there is an ever-increasing role of mutation-specific and checkpoint inhibitor therapy in the advanced disease. And with this, I thank you very much. At the last couple slides, I included some bibliography that's pertinent to our discussion, and shukran jazilan min Miami. Thank you so much for your attention.